So every year at FutureDoc, we get a real interview for you to look at and review, and usually we keep it a secret as to where it's from so that you can guess. But this year we'll tell you off the bat that it's from Cambridge. So I hope you find it really useful. As I'm hoping you'll realise from this, don't underestimate interviews. Early prep is really important. Good quality help matters as well. So if you want to find out how you can get the level of support that is going to get you through an interview like this, check out this video here where we talk about the FutureDoc program. And stick around to the end because I'm going to show you a free gift that you can get as well that's going to help you with your interviews and just help you understand what you need to be doing to get to the level needed to get into medical school and secure that place. So enjoy, I'll see you after, but I hope you find this really useful.
Okay, so hi Leonor, my name is Julia. Today we'll be doing one of your panel interviews for Cambridge. So I'll present you with a series of questions and I would like you to view this as a form of discussion. Does that sound good?
Sounds great.
Perfect. So I'm going to start asking you, I've been reading your personal statement and I saw that you've been doing some research on Cushing's, and I want you to tell me a little bit more about Cushing's and what you know about the disease and things like that. So
Yes. Cushing's disease or syndrome is when the body has an excess amount of cortisol in the blood, and this can be either environmentally influenced or it can be influenced by things from within the body, such as pituitary tumors or adrenal tumors as well. What I looked into my research was how the disease works, how it's treated, and how its treatment has changed over a period of time. Like when I first started looking into it, I saw that the excess amount of cortisol from environmental causes is often due to medications like steroids. This can be often people who have asthma or people who take steroids for like bodybuilding or performance enhancing purposes. Those people, when prolonging their use of those steroids, they end up having too much cortisol in the blood because it is a steroid hormone. So yes, and essentially how it ends up being secreted is when ACTH is secreted from the pituitary gland, sorry, and it basically activates a cascade within the adrenal cortex, I believe, and from there the cortisol is secreted into the blood. And what that cortisol does is it has a huge variety of effects on the body, such as it can lead to increased glucose in the blood, hyperglycemia, I think. It leads to gluconeogenesis, the hydrolysis of proteins and lipids in the body as well, which is why often a symptom of Cushing syndrome is muscle mass loss, sorry, poor, more brittle bones as well, and fat storage in like the kind of the more central region of the body, like the torso. And yeah, that would be environmental causes, but essentially when it's caused by something within the body, those tumors that attach to either the pituitary or the adrenal glands activate that same like cascade depending on where they are. They either directly cause cortisol secretion or cause ACTH to then cause cortisol secretion. The symptoms are relatively the same, but the treatment is what's different, and that is what I explored.
okay.
Yeah.
Thank you so much for sharing that with me. So I'm going to move on to the next question, completely different question. So I'm just going to share my screen. Just give me a second. So I'm going to share my screen and I would like you to describe this molecule. Just describe what you see. Sorry, that might take a sec to load. Let me know when you can see it and just describe this molecule to me, please.
All right, it's on my screen now. All right. It's an organic molecule for one, I think. chloride. I can see a C-double-O bond, so this could be a ketone. There's also a carbon-oxygen single bond as well in the middle. It's got, I think that's 4 carbons there. Wait, hold on. 1, 2, 3. Yeah, 4 carbons. We've got an amine group with I would like to say an extra hydrogen attached. That's what causes that positive charge on the nitrogen atom, I think. And there's also a chloride ion, which I don't think is attached to the molecule. It just seems to be there.
Yeah. So what the chloride ion in there means, it just means this molecule is a salt. So
Okay.
for example, table salt will be sodium and chloride. So this molecule is a salt because it's got the chloride. So thank you for describing this molecule. I have a few follow-up questions about the molecule. So the molecule that I've shown you is acetylcholine, which is a neurotransmitter. It's okay if you don't know much about it. That's not the point of the question. But you've described the molecule really well. So I have some follow-up questions about this molecule. I'm going to present you with a molecule again. I'm just going to share my screen again. And let me know when you can see this screen. So I'm going to put it in big again. It might take a little while to load. So you've got the molecule in here presented to you again. I've broken it down for you. And what I want you to calculate, and please ask if you need any guidance on how to do so, but do try to do it yourself, is the molecular weight of this molecule, which is adrenaline. So I'm just gonna, acetylcholine. I'm just gonna let you work through this and do let me know if you need any help, okay?
All right, sure. I've got my calculator here.
Perfect.
So we've got 1, 2, 3, 4, 5, 6, 7 carbons. We've got 2 oxygens. Got 1, 2, 3, 5, 6, 7. 16 hydrogens. Yeah. And we've got 1 nitrogen. And lastly, we've got the chloride. So that would be 84 plus 16 plus 16 plus 16 again plus 14 plus 35.5. That would be 181.5.
Perfect. So I'll tell you what my value is, and I think it might be slightly different, but not too different. So nothing to worry about. It could be due to decimals and things like that. So can you repeat your value to me, please?
181.5.
Perfect. So I got 181.66. So that's very good. And would you say this is a high or a low molecular weight? What do you think?
I mean, it's not the lowest I've seen, but certain molecules can go up to like huge molecular weights of like in the thousands, but I would say it's quite large relatively, I'd say.
Yep. So we've established that it's a large molecule. As I said to you, is acetylcholine, which is a neurotransmitter. So with it being a neurotransmitter and having quite a large molecular weight, like you said, what kind of chemical properties do you expect this molecule to have? And I can show you the molecule again if you want. Maybe that will help you answer the question. So you can just, try and explain to me, what do you expect from a molecule like this? How do you expect it to behave in the body?
Sure. I see it's got charges. I'm not sure how these charges may like influence certain biochemical processes in the body, but this could possibly, it's quite large and I wonder, does this molecule have any like polarity to it?
Yeah, it does.
All right. It could be water soluble then. Hmm. It's also quite large, so I can't imagine it being able to cross a plasma membrane without like additional help from a protein,
I
a
agree.
carrier protein specifically, or
Mhm,
another cellular process to transport it in.
mhm.
Um, hmm.
Do you think I agree with what you've said? So you've said it's got charges. You said it's polar, hence it's water soluble. So you said that you can't imagine it being able to diffuse easily through plasma membranes. Do you think that's a good thing? Do you think that kind of suits his role as a neurotransmitter, or what do you think?
Hmm. As a neurotransmitter, um, it crosses between, no, sorry. It is secreted by like a presynaptic membrane to then cross the synapse.
Hmm.
I think this would depend on what, like, I would like to say if there's like a fluid, possibly tissue fluid between the two, like the two neurons, or hmm, if it's going to diffuse across that, it needs to possibly be soluble in that. And I'd like to say I'm just thinking like its shape needs to be specific to what are they called? Acetylcholine receptors on the other
Yeah,
neuron, the postsynaptic membrane.
yeah. So quite
Yeah,
Go on, sorry. So quite a specific kind of interaction. I think,
absolutely.
yeah, I agree with you. You don't want it to be floating around everywhere. So if it was fat soluble, then it means that it could easily go anywhere in the body and you wouldn't be able to control where it is and how it acts on the human body.
Precisely.
Um, I don't know how much you know about this molecule specifically, acetylcholine, but can you try and guess what kind of role it has in the human body?
Mm. Um, it is a neurotransmitter, so it's involved in crossing the synapse by diffusion to kind of trans. I would like to say transfer nerve impulses from one neuron to the next in nervous communication. This. I think. Correct me if I'm wrong, but I also think it is the neurotransmitter you'd find at a neuromuscular junction.
Yeah, I agree.
Yeah.
That's completely right.
Yeah, and in a synapse, a cholinergic synapse, the synapses which are between two neurons and have acetylcholine diffusing across.
Hmm.
I think it has both excitatory and inhibitory.
Hmm.
Um, it can trigger both kind of reactions. It can either stop a nervous impulse from continuing to travel through the nervous system, or it can cause it to continue traveling, if that makes
Yeah,
sense.
yeah, yeah. No, I agree. That makes complete sense. So you've described the role of acetylcholine really well. I agree with you. So it's got a role in muscle contraction. Like you said, it acts in the neuromuscular junction, and it does this through specific subtype of acetylcholine receptors. So it does this through nicotinic receptors, which are found in skeletal muscles, and it triggers muscle contraction to facilitate movement and things like that. And then, like you said, it also acts in nerve transmission, so neuron to neuron, and it actually works in the autonomic division of the nervous system,
Hmm.
like sort of like people tend to refer it as like rest and digest. So,
Oh
it
wow.
affects things like your digestion and your secretion and things like that. So I agree with the way you explain the roles. You're completely right. And because you've guessed really well how it acts on the body, I would like you to describe to me if you wanted to design an experiment to see how acetylcholine works in the body, what sort of things would you do? How would you design this experiment?
Hmm. That's quite interesting. Wow. Um, right. If I were to design an experiment, um, for one, I would have possibly a control group to see how like do certain processes happen without acetylcholine, so that we have that contrasting of what exactly it's doing. Um, I'm just thinking, how exactly would we do this? Hold on.
Up to you. So what is your objective on this experiment?
Is to investigate the effects of acetylcholine on the body seems very broad.
You can narrow it down to whatever you want. It's your experiment.
All right. Let's say the role of acetylcholine in nervous transmission.
Yep. For example, that's good.
All right. So if we were to investigate that, we'd want maybe let's say 3 different neurons. One with one which is made to secrete a small amount of acetylcholine, one that is made to secrete a larger amount, and one that secretes none at all.
So low amount, high amount, and none at all. Okay. Which of these is your control?
I think the one with none at all would be the control.
Do you know what type of control it would be?
I'm not sure. No.
So that would be your negative control, right? Because nothing is happening there. So that would be negative control, because with that control, you find out what happens in the absence of acetylcholine. If you, for example, wanted to test what happens if you block acetylcholine, you would need a positive control. So you would need a neuron where there is acetylcholine, but there's no blockage. So that's the difference between a positive and a negative control. But I like your thinking. So go on. So you would have 3 different neurons. What?
Yes. So in the neuron that's made to secrete a smaller amount, maybe and hold on, I'm just trying to think about how exactly it's secreted again. I think it is calcium ions that enter and that is due to an incident action potential on that presynaptic membrane. So if a smaller potential difference were across that membrane, then that would cause that smaller amount of acetylcholine to be secreted. And in the second neuron, we could put a larger potential difference across said neuron, and that would cause those more calcium ions come in and more acetylcholine to come into that synapse. And in the one with none at all, either no action potential, or you actually gave me an interesting idea, was having a competitive inhibitor in the acetylcholine receptors on the postsynaptic membrane.
Yeah.
I'm not sure what specific competitive inhibitor acetylcholine would have.
That's fine. So it's called curare, but we don't expect any student to know this at this stage. But it's good thinking. I would also definitely think about using a competitive inhibitor so that we can understand what's the baseline functioning of that neuron with and without acetylcholine. I would say if I was to design an experiment, I think using 3 different neurons would be really complicated because they are really, really small. So it would be really difficult for you to work with those kind of concentrations. There's a technique called patch clamping, in which you can work with specific neurons, but it's known for being really, really difficult. But I like your thinking. We're going to move on in the interest of time to my last question before we go through some feedback. And I'm going to show you a completely different graph. So forget about neurotransmission. I'm just going to show you this graph. And I want you to take your time and look at it. Let me know if you can see it properly. Just describe what you see to me, okay?
All right. So in this graph, we can see on the y-axis, we have ibuprofen plasma concentrations in micrograms per milliliters. And on the x-axis, we have time in hours. And it goes up to 24 hours. And oh yeah, on the y-axis, it goes up to 40 micrograms per milliliter. Yes. We have, I would like to say, ibuprofen administered to, I'm going to say that the blue and red line indicate like a certain like patient or group of patients who have been administered ibuprofen whilst fasted and ibuprofen after breakfast. We can see that there's quite a significant difference in the concentrations, the initial concentrations of ibuprofen after being administered, I'd like to say. In the fasted individual, it peaks at 40 micrograms per milliliter, and it peaks much sooner than the when taken after breakfast. I don't think that even peaks at 20 micrograms per milliliters yet. I'd like to say 18 micrograms possibly. And then afterwards, they both have a exponential like decrease in the concentrations in the blood, or somewhat exponential, or a slow, a decrease at a decreasing rate, if that makes sense.
I agree.
When taking it fasted, I think the levels drop, and does that reach zero at about 12 hours, or like very close to zero at about 12 hours?
I think they both do.
I see. And at about like 24 hours, the ibuprofen taken after breakfast is when it gets to zero. Yeah. So yeah, there's quite a stark difference in the amount of time it stays in the body. But near those 12 hours, it doesn't seem to, there doesn't seem to be a huge difference in the concentrations. But I would say to like properly get rid of it from like the plasma.
I agree.
Yeah.
So the peak plasma concentration, so this is what we call the peak plasma concentration. So the highest it ever gets is much higher when someone's fasted, but we reach that peak much sooner. So we reach it a bit before the hour, whereas it takes us almost maybe an hour and a half, a little bit longer, once we've had breakfast. So the absorption, how fast it gets in the blood, is much quicker when we don't have any food in our stomach. So I have some questions about that. So you've described the graph really well. You've described the trends and the observations quite well. So what are the clinical interpretations that you can draw from this graph? What sort of, clinical findings, or what kind of implications do you think this graph has?
I think that hold on. If you take it after breakfast, the levels that enter your blood, it enters your blood slower, and also there ends up being a lower concentration. I'm not sure what implications ibuprofen could have on the body if it's in far too high concentrations. But I think it would be better to take it after a meal or after breakfast, so that it's much more like controlled, I would say, and so that but I don't know, it really depends, because I'm not sure like what an unsafe level of ibuprofen would be, and if you are in quite like a significant amount of pain, possibly that that higher concentrations earlier on would be ideal. I mean, if it's not a dangerous level, if it's completely safe, of course, that's the main barrier, I think.
Yeah, I agree with you. So you said if someone was in a lot of pain and they wanted to get that really fast pain relief, it would make more sense to have it fasted? I agree with you. Obviously, you've stated that you don't know the safe concentrations in the plasma. That's not relevant for this question, as in it is relevant, but we don't expect you to know that number at all. So I think that's really, really good reasoning. But then can you think of any reasons why we would want that slower release? So why would we recommend to a patient to have ibuprofen with food rather than on its own? Can you think of any kind of reasons?
Hmm. Maybe the slower, hmm, maybe like the slower kind of release and possible effect of ibuprofen. Um, I'd like to say it could stop a patient from either like taking too much
Mhm.
or I don't know. The graph also seemed to have rather than like the decrease seemed less steep. I'd
Mhm.
like to say for maybe a longer effect and not having to like retake the drug.
Yeah,
I think that would be a big reason to take it not fasted, is so that you don't
yeah,
have to take it again
yeah. I
and
agree.
possibly have like negative implications on the body or build too
I
much dependence on it.
Yeah, I agree. So that's what we call sustained release. So it means you take one and it takes longer to be released on the blood. So then you have like longer lasting effects. So for things like completely unrelated, but for things like insulin in patients with diabetes, we can have different
Mhm.
speeds of release in insulin. So patients could have like one slow release insulin that just keeps their levels at like a steady, safe level, and then they could have like a much quicker release one to have after a meal. So that's what we call
Hmm.
sustained release, so that it has longer lasting effects. And we can play with that. It's beyond the topic of conversation, but we can definitely play that with medicines to achieve what we want. So I have one last final question about this graph. And like we've been talking about ibuprofen, and I presume you know that ibuprofen is used for pain relief.
Mhm.
So if you wanted to design a clinical study, so previously we were talking about a study with neurons and tissues and things like that. So I'm now asking you about a clinical study with patients. If you wanted to design it so that your hypothesis was to see whether this faster or slower absorption affects pain control, how would you design this experiment? What sort of things do you think you would need to factor in?
Hmm. Um, So would this be the effect of ibuprofen either fasted or unfasted? That were okay. I see.
It's your experiment, so you
All
tell me.
right.
Yes, that's what we want to see.
All right, sure. So, off the top of my head, maybe two different groups of patients.
Hmm.
One that has a meal prior and one that doesn't.
Hmm.
Um, hmm. And another thing that we could possibly consider is like different like demographics rather than because like someone's weight, age, diet, lifestyle, and also the amount of pain that they're in. These could
Hmm.
all be things that could actually influence the results. And yeah,
Do you know what we use to account for those different factors to make sure that we don't select a specific type of people? So, for example, if we want to research the effect of pain, we don't want to just choose people who are in pain, because then we don't have those controls. Do you know how we choose people from like a big populational sample for a study?
hmm. Possibly a couple of people to represent each sort of demographic, I'd say.
Yeah.
Maybe someone who's in, I mean, pain is quite subjective, but someone who is in, per se, a lot of pain due to possibly a recent surgery or or like a leg injury or something. Maybe someone with an abdominal pain, someone with headaches,
Mhm.
and some people who maybe don't experience much at all.
Mhm.
Hmm,
Yeah.
I think.
Yeah.
Um,
So
yeah.
well explained. What I was trying to get at is a randomized control trial. I don't know if you've heard this before, but it's kind of similar to what you've explained. So we want to with a randomized controlled trial, we want to test the effectiveness of an intervention, and what we want to do is to compare a group that has this intervention and a group that doesn't have this intervention. But the participants and how we assign the participants. So, for example, if your intervention is ibuprofen for pain control, you can't have all the participants in the ibuprofen group to have pain and the ones in the non-ibuprofen group to not have pain, because that's like skewing your results. So you want
Absolutely.
a randomized controlled trial, which means you get a large population sample and you assign them a treatment at random. So the experimenter, in this case, you don't say this person's going to have this treatment, this person's, because then you could be biased either consciously
Absolutely.
or unconsciously to assign people a treatment that you think might be better for them. So that's how you control and you reduce the bias. It's called randomization. And randomized controlled trials are really, really standard in scientific practice. So I agree with your reasoning. Sorry, I've kind of interrupted you. So you said you would have a group of people, you would account for different demographics. Would you do one type of pain or many types of pain, like you were saying?
I think for the sake of trying to keep it a bit more specific, maybe we could either conduct like different experiments, like investigating different types of pain, but for the sake of this specific one, maybe we could look at abdominal pain because
Mhm.
it's experienced by a lot of people in the population,
Mhm.
and there's only so many things that can cause abdominal pain as opposed to general pain, if that makes sense.
Yeah, yeah,
Um,
I
yeah.
agree.
Another thing we could maybe incorporate is a placebo drug.
Yeah.
Um, like have, like you said, to eliminate bias, have a computer say, okay, X patient is going to get ibuprofen, Y patient is going to get a placebo, um, and invest it and see how their like pains or ailments like kind of change over a period of time.
Mhm. Mhm.
Um, and like in terms of the data, we could both ask the patients how they're feeling, although that's quite subjective. So we could also possibly test their plasma concentrations for that drug as well, to kind of see, okay, at X concentration, patient was feeling better, not as much better as maybe a different patient,
Mhm.
and we could like record that and be able to possibly like analyze that to reach a conclusion.
Yeah, so that kind of alludes to what I wanted to ask as a follow-up question. So I think your reasoning is really good there. So you said that we're obviously assessing pain, so our outcome is pain, but how would we measure and collect that outcome? Because like you said, pain is quite subjective. So how would you ensure that you're having an objective measurement when talking about pain? What sort of parameters can you think of that we could include in our study?
Mm. Like pain is extremely subjective. It's
Mhm.
I don't want to say people feel it differently, but they interpret it differently. Like
Mhm.
someone might be like, oh, okay, it's just a bit of a soreness, but some people may be like, oh my god, ow, that really hurts. Oh my god. So I'm just trying to think of a way to quantify it, to be honest. Like without it's much harder to compare without those like kind of like quantitative figures in place.
Yeah.
But maybe asking people to describe their pain, like is it
Mhm.
sore, is it stabbing, is it less sore, is it less stabbing than before, do you feel it somewhere new?
Mhm.
And maybe you could create like a bar chart saying after
Mhm.
12 hours, x amount of patients said that it was less sore or less of a stabbing pain, no difference, and what the placebo group felt in that same amount of time, I think.
So maybe something like a pain diary where people could report their
Oh,
pain over time, something like that. Because I agree that you said pain is quite subjective. It's definitely a very broad experience that encompasses psychology, biology, the social environment of a person, but also their physiology. So I agree that pain is a subjective experience. However, if a patient comes to us and tells us they're not in pain anymore, that's their subjective perception of pain, but that's definitely a positive outcome, right? So
Absolutely.
we should definitely keep a subjective scale of pain somewhere. Can you think of any objective physiological parameters that we could associate indirectly to pain or to pain measurements?
You could say how much it like affects someone, like what they're trying to do, or how much it affects someone's daily life.
Yep.
Like if a pain is absolutely debilitating and you're like bedbound, then I think that's quite like an extreme amount of pain. However, if you're able to go on a walk, do your work, maybe even like do something more physically strenuous, like lift something, you may be feeling a lot less pain than someone who is bedbound because they're in so much pain.
Yeah. So
So
maybe like a level of function, overall level of function.
yeah.
Perfect, perfect. And any sort of parameter that we can measure physiologically, anything at all that you can think in someone, how does people physiology change when they're in pain? Can you think of anything at all?
I I'm sort of thinking of the fight or flight response. Could maybe adrenaline levels in the blood.
Yeah,
When someone is in a lot of pain, the body may interpret that as being in danger or like being at risk of something.
yeah,
That could increase those adrenaline levels, and if there were a way to measure those concentrations in the blood at a certain time,
absolutely.
that would be a good parameter, I think.
Absolutely. So that's what I wanted you to get at. So the fight or flight response, we could have things like adrenaline in the blood, like you said, but we could also something really cheap and quick and easy would be to measure someone's heart rate or to measure their blood. Because when we're in pain, our body develops this fight or flight response. So things like blood pressure, but also definitely measuring hormones and neurotransmitters in the blood that could signal pain. So I agree with you. That was a really good design of a clinical study. So that is the end of our interview. We did roughly 35 minutes. I'll give you some feedback, but I guess my first question and the first thing that I'm more interested in is how did you feel during that interview? Did you feel quite comfortable? Did you feel like that there was something that didn't go particularly well? Is there anything that you're, thinking about before I give you my feedback?
I'm quite happy with how it went. I think I gave it my best shot. I felt quite like on edge. I don't think there was a moment where I like stopped thinking. Like I was constantly thinking like maybe this, maybe that. And I overall found it quite fun and it seemed like quite like a conversation between clever people, and I really enjoy doing that.
Yeah, that's exactly, I guess that's the ideal outcome of the interview. That, I enjoyed interviewing you, and I'm happy to hear that you enjoyed being interviewed, because when I did my Cambridge interview, I actually really enjoyed it. And there's a lot of, really scary information about the Cambridge interview, but what the interview is trying to do is trying to replicate the learning that you will have in Cambridge, is trying to replicate that kind of small group teaching that's really specific to Cambridge and to Oxford, um, to see if the student enjoys it and to see if the student feels comfortable. So they don't do this panel for no reason. They do it because this is how you will spend, especially the first 2 years of your course learning. So that's why they put a lot of emphasis on this kind of discussion that to a lot of people might seem really scary, but I think you were definitely comfortable. And I think, apart from the content in which I could tell you were comfortable, I think overall the way, you presented yourself, your non-verbal kind of language was really good. And I think that's also really important because, like you said, we focus a lot on, trying to sound clever and trying to say really clever things, but ultimately you're not applying to a course where you just need to be clever. You're applying to a course where you need to be really kind and you need to be nice when you speak to people. So they're also definitely indirectly testing how good your communication is and, overall they want to see, is this a person that we want to invest a lot of resources and a lot of time in training for 6 years to be a doctor? Are they going to make a good doctor? And it's really hard to know if someone's going to become a good doctor when they're 16, 17. But I think you definitely have those like communication, and I think you were really, really good at thinking out loud, because I know at some points you maybe weren't so sure about where the answer needed to go, but there's never, I mean, there's definitely a lot of wrongs, but like there isn't one right answer. And I think in the moments where you weren't sure about the answer, you really let me guide you, and you were listening, and you reacted quite nicely when I said, actually, this is this, or this is that, or because it's great to be really clever, but if someone tells you that you aren't right and you can't adapt your thinking and you can't take that in a positive way, or in like if you can't view it as a learning opportunity, then they probably won't enjoy teaching. And we forget that like a lot of people, they get really upset if they get told they're wrong. So they're also testing how, realistic into your abilities are. You must never forget that you're talking to people who are experts in whatever subject.
Absolutely.
So I think you did really, really well. So we'll go through some like individual feedback. So I mean, the first question I asked you, sorry, the first question I asked you about your research, always I included that question because they might not do this in other universities, but they definitely look at your personal statement, and any books, anything that you talk about, any research project, any illness, anything that you talk about, you should be ready to comfortably explain it to your interviewer, which you completely explained really, really well. I find Cushing's quite difficult, so that's why I chose it, because I think as I say, if you are going to choose a difficult topic, make sure you know the basics. They will not ask you about Cushing's in too much detail if you don't mention it, but if you mention it, they will.
They will grow. They will grow.
Yeah, exactly. And you were talking about like, I think you did a really clear intro, and then you went more specifically into your research, and you were talking about exogenous, I think you called it environmental. I guess the more medical way is like exogenous steroids or endogenous steroids.
Endogenous, yeah.
But that's like a minor thing. And I think you knew your axis quite well. I think you got a bit flustered at first because you said hypothalamus, and then you went on to pituitary. Just make sure you know your axis really well, because I wasn't mean about it, but they could ask you, what does the hypothalamus do, and all of this. What happens if you suppress that? So endocrine axes are, if you get them, they're really easy, but I find them quite difficult. So make sure to be able to talk about endocrine axis if you've mentioned Cushing. So that question was more for you to explain your own research. So there wasn't that much I could have, as long as you know what you're talking about. And then the second question, so I'm going to show you some feedback or how I would approach a question like this, because I think it's challenging when you're presented with a molecule that you have no idea about. I think this is the kind of question that is testing how you can think on the spot. And I think, you said it's an organic molecule, I think, which is quite nice because you are navigating uncertainty and you are being humble and you're not like 100% sure. So you're saying, I think, which is quite good, because I think if I was at your stage and I was presented this, I also wouldn't be talking with a lot of confidence about a molecule that I don't know. So you described the backbone quite well. You identified this weird chloride in here. You identified the ammonium in here, the quaternary ammonium, tertiary ammonium. And then you said you thought this was a ketone. So my recommendation, this is the ideal answer, which I don't expect you to know. But my recommendation is that you learn the functional groups.
Yeah.
Because you guessed the ketone really well, but they could, give you some other more difficult functional groups. So it's just quite nice to be familiar with functional groups. So the ideal answer would be for you to know what molecule is. However, that's just not the point. And the point is not for you to recite or to like memorize what a molecule is, but rather for you to do what you did, which was you recognize some functional groups, you recognize things that you weren't so sure about. So the chloride being there, you were like, there's a chloride, I'm not sure what it means. But then when I explained it to you, you were quite good at like understanding, okay, that's a salt, that's fine. Just recognize, nomenclature basics, like what an alkane, alkene, and alkyne is. Just apply your basic chemistry to an unknown question and you'll do quite well. I wouldn't recommend you memorize many molecules, but maybe something like glucose or the basic amino acid structure,
Yeah.
like that is quite good. Or if you see a super large molecule, you can recognize that that could probably be a lipid. And if you don't know, always ask for help and ask for guidance, because that's the best way to go about it. So I'm just gonna skip over this. You reason its function quite well. So this is just me explaining how I would approach this question if I didn't know. So I would describe it. I would try to reason what the function means. And if I didn't know, I would literally ask for some clarification, because what they don't want is for you to be stuck in a question and not be able to progress from there. So always ask for help, because these questions are difficult and they're difficult on purpose. So then I asked you about its molecular weight, which you did perfectly well. And I like that instead of going super quiet, you started reasoning with me, and well, not with me, I was just listening, but you started thinking out loud and you solved the question really well. You had your calculator, you were ready, and you actually got the number completely right. So that's really good. In terms of chemical properties, so you said it was polar, which makes it water soluble. And then I think you said that it was charged and you were unsure of the effect, which again, I quite like, because you were navigating the uncertainty quite well. And then I don't know if you said this before or earlier, but I think you said because it's water soluble, then it means it probably can't diffuse through the lipid membranes of cells really easily. So it will need some form of transporter or channel to move across, which I agree with. So you did really, really well with the answer in here. And then we talked about its role. So how would it act on the human body was my question. And I'm really impressed, because I wouldn't expect you to know too much about it, but I think you guessed quite well that it works in nerve impulses in the fight or flight response. Well, actually, no, sorry, in the rest and digest, so in the autonomic nervous system regulation, parasympathetic kind of branch of the autonomic nervous system, so the opposite of fight or flight. And then you were very good at identifying that it works in the neuromuscular junction. So I was really impressed with that. And then we moved on to the experimental design. So I think a structure to follow when you're doing experimental design is, before you start describing an experiment or before you start assigning groups and like deciding what to do to who, the first thing I would do to make sure that you sound structured and that you sound clever is, what is your objective? Because that's going to help you narrow down what you're going to do. Whereas if you start trying to tackle everything, you're going to make your life really difficult. And I think in an experiment, the more you narrow your objectives, the better it's going to be, and the more objective the outcomes are going to be.
Yeah.
I think, I wouldn't do the neuron thing, like I said, but I think, it makes sense. Like, you're not a researcher, so I don't expect you to have done these experiments before. So what I would do is, because if we were testing how it affects muscle contraction, I would get a piece of muscle and I would find a way to measure how that muscle is contracting, depending on how much acetylcholine we're adding. So again, I think your logic was really good. It's just a different answer. And this goes to show that there is no one right answer or wrong answer. And I really like that, you identify that you would need a control and you could use a blocker and things like that. So again, I think you approached a question that you had never like seen before in a really logic and like sciencey way, which is what they want. So moving on to this one, the graph. Perfect, because I think the first thing you did before like explaining any medicine or any logic or anything was like, what's in the y-axis, what's in the x-axis, what are the units, like what are the ranges? That's the best way to go about any graph. You will not make a mistake if you literally, before making any interpretations, you just read what's the graph showing. And then I think I asked you, well, I think you, after described like how it looks like, you described what it meant, and like, as in like, you know, we peak at this, well, you didn't say peak plasma concentration. That's like a really specific thing to say, but I think you said that, you know, it gets all the way to like 40, whereas in the after breakfast it only gets to 20 or something like that. So again, I think you identified it quite well and is a bit more sustained, whereas the drop here is like
Yeah, it's much more
radical.
abrupt.
Yeah, exactly. So I think your description was really good. This is just the kind of previous knowledge that you would need to tackle, you would need to have to tackle the question. So literally like how to read a graph, understanding that if something peaks really quickly, then it means the absorption is really fast. And then the fact that ibuprofen is used as a painkiller. I think the only thing that you didn't identify is that, and again, it's like beyond what you should know at the moment, is that if you take ibuprofen on an empty stomach, you can get a lot more like gastrointestinal side effects. So things like ulcers or acid reflux or things
Oh,
like that.
fair enough. I see.
So that's the kind of second bit that I was trying to get you to
I
think
see.
about. You described it really well. You described the trends quite well, and I like that you use specific numbers and you use like, well, I guess I had to guide you for the peak timings, but again,
Oh, yeah.
you definitely said this, that like after 12 hours, they both kind of get to similar level, and there's barely no levels after 24 hours. So I think that was really good. The clinical interpretations, I think, again, really good, because you said if someone is in a lot of pain, then they might want to take it in a fasted stomach so that then the plasma concentration peaks a lot sooner. Whereas I think maybe because you didn't know about the GI side effects, but you
Yeah.
definitely identified that if they take it with food, then it's not going to peak as quickly, but it will be a bit more sustained. So
Yeah.
that means that people may have like more sustained pain relief. So again, you used information about things that you didn't really know much about. You did that in a really good, like structured way. Let me just see what other feedback I have in here. I think the following questions, I didn't ask you about this, but I think it's because we talked about it already, about whether you would take it with food or not.
Yeah.
But when I asked you about designing a clinical study, I think again, you were really structured, and I think I like that you identified that we need different demographics to kind of make it representative, because if we're only sampling men in their 50s, then we don't know how age or sex affects that. So that's
Yeah.
where the randomization came into place, and I explained you a little bit about it, and you were like super open to my explanation. And then I think you also talked about placebo, so that would be your negative control in here. And then lastly, when I asked you about how would you assess pain, because pain is such a subjective experience, and you know, I mean, I guess you were the first one to identify that, which I really like, because that's definitely true and that's definitely important. So getting the patient's perspective, but then getting their level of functioning, because someone may say they're in a lot of pain, but you know, they can get to work, they can look after the kids, they can do whatever they would do if they weren't in pain. So that means it might be really painful, but not as debilitating. And then I was trying to get you to speak about like the fight or flight response. And I was really happy when, you know, I didn't have to guide you. You just kind of had that light bulb moment, and I could see it, like your
Yeah.
brain
I
working.
was like,
So
wait, hold on. It's like that hold on moment. Hold on. Yeah.
exactly. So I think that was excellent. I think I don't know how much prep you've done, but I think you're really well prepared, and I think the fact that you enjoyed it is super important. So that was really, really nice.
Okay, I hope you found that really useful. Like I said, you can get a free resource from us, which is basically a free interview guide. So have a look below in the description where you can download one of our free resources, but check out the free resource page on the Future Doc website for anything that you need related to medical school. Also, like I say, if you want some help, the Future Doc program has an incredibly good success rate with getting people into where they want to be. And also we have a guarantee around it as well. So you really we've got your back to make sure that we're doing everything in our power to get you there. So thank you for watching. I'll see you in the next video. Hopefully maybe see you on the Future Doc program to help you get into your chosen medical school.